about, okay? Actually, sorry, these are gonna help move your lenses about. These right here are small little cup graspers. So they end up working almost like your biopsy forceps. So if you want a quick little biopsy, you'll see inside there's little sharp cups where they can go ahead and take little biopsies from within the eye. They need to send these out. Okay? So take a look at those when you guys get a chance. Open them up so you can see the little cups on the inside. Over here we have calipers. So if we need to measure the eye, right? How does the caliper work? The caliper, if you open it and you place it somewhere, you can tell the size. But you can also tell inside, you can tell a pretty much diameter or so by doing this, okay? So that's how the caliper works. Either the size, see, or the inside of a diameter of something, okay? So that's why they use in eyes. Sometimes the doctor will need to find a certain size, cataract or something they have. So what the doctor will do is they'll measure, lock it in place, and they'll draw dot, 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 so they can get that same circumference of circle, okay? Nowadays we have instruments that are round already and they have different sizes. All you need to do is dip it in ink or color it, and the doctor will just press on the eye, and now you got a tattooing of where you need to cut. Okay?
Do we still use it though sometimes?
You guys not watch the video, huh?
Do we still use those sometimes though?
Yeah, they still use those. I had one of the techs tell me they use this for a circumcision. So this is not just the eye, but so they can measure certain measurements and stuff. All right, and then we have these guys. They look like forceps until you look really close. They have that pressurized system. Anything that has this has a pressure feedback. So once you press, you'll know when it's going to want to come back. Why? You don't want things in the eye to automatically shut and then stay shut. You want things to bounce back unless you make a mistake. They're able to give you a little feedback. These are Westcott tenotomy scissors. Tenotomy scissors tend to have a taper on the end, okay? They taper so that not only you can dissect, but you can give blunt dissection on the outside, kind of like your Metzen bombs. Metzen bombs are cut on the inside, dissect on the outside, right? But these are more made and engineered to have the outside dissect. So that's why they have that curve, so it can help dissect during eye surgeries, okay? So these Westcott tenotomies, again, very small. If the scissor had this, but it had rings on it, then it'd be a tenotomy. Since this has that pressure kind of pinch forceps, it becomes a Westcott tenotomy, okay? So we'll go and reference back tenotomies when we do orthopedic surgery. Because teno means tendon, right? Otomy means remove. These scissors are made to get into a tendon, dissect the coverings of the tendon, so we can release the tendon. But we like to use those now in eyes, so they are now the Westcott tenotomies. All right, so here's another version. And here's another scissor. I totally forgot what this one is, but it's in there.
That one's tiny.
All right, and then what about needle holders, right? We have these guys here. These are needle holders, okay? Castro Viejo, and then needle holder. This one has what?
Does it have a locking mechanism?
Gold, tungsten carbide, right? This is also a needle holder. It just doesn't have tungsten carbide. Castro Viejo, possibly Castro Viejo, okay? Learn Castro Viejo. Other names of these are going to be McPherson. McPhersons are a little longer and skinnier. Castro Viejos are your general ones that you're going to need. You can give them a McPherson, your doctor will still say it's a Castro Viejo, okay? They know Castro Viejos. Castro Viejo is a vascular type instrument anyways. Dr. Castro Viejo is more vascular, but microscopic vascular. So this falls into the microscopic family of instruments, Castro Viejo, okay? Definitely you need these. When you're using sutures from 6.0 and above to about 10 or 11, Castro Viejo. Anything higher than 6.0, where you start getting to 5.0, 3.0, 2.0, 1.5, then you use regular ringed instruments, okay? So because of eyes, your eyes are usually going to range from 6.0 to 11.0. You use Castro Viejos instead, okay? Get to learn how to work these. These are meant to have that pressure release. Again, you guys got to do this nice and softly until you feel and hear the little click. And you don't click through. If you don't do it right, as gentle as I'm doing it, it still doesn't click right. I'm not mashing it either, but I'm not doing it correct either. You're supposed to have that nice little click. It's more of a feeling, more than a feeling. the Boston grip. It's more than a feeler.
Boston.
All right, so when you guys come up here, get to work with it, practice on closing it. This one's a little harder because it's a little stiffer than the other one. Okay, get to working with this so that it locks. All right, and then your syringes are going to be of a smaller size, right? Why? We don't want to over inject the eye. There's barely enough pressure in there. We don't over want to pressurize things. And after most surgeries, we're going to have a tenometer, right? Because the tenometer is to make sure to measure the pressure around the eye. Because if we're injecting stuff in there, we want to make sure the same pressure of the eye is there, okay? So we also don't want to inject too much. More than likely, you're going to be dealing with like 0.1s or 1s or 0.5s or even a 5 or even a 3. This is a 3. But 5 is going to be your major size in here. You don't want a 10 cc for eye surgery. If you do have a 10 cc syringe, it's for irrigation, okay? If you're going to irrigate, you're going to want to make sure you have an olive tip irrigator or a catheter type irrigator that is nice and soft for the eye. If you don't squeeze this tight enough, and it should be hand tight, this can pop off during the surgery, okay? So how do we prevent that? We make sure we have things that won't damage the eye. So we don't use needles on this. We use catheter tips or olive tips. There's some olive tips, which means it just has like a little olive on the end so it doesn't damage you while going around the tissue. And why 10? So you're going to be irrigating and suctioning the wound during the case. Yes.
Wait, what's an olive?
An olive, like you eat an olive?
Oh, like just like a ball.
Shaped like an olive at the side. So they're called olive tips.
Okay.
So they're usually small. In this case, we have these. We don't have the other olive tips. This guy here, just to show you, it's a protective needle. If you guys haven't worked with this, as soon as you inject someone, you take this out, it automatically locks so that you don't get poked. Just
Don't do that.
this guy over here. So you're going to have a lot of cystotomes. Cystotomes for eye surgery is pretty much one of these guys, but with a needle on it, and not on a hypo needle. This is actually flat, or has a little cutter, or has a little knife on the end. These are cystotomes, and they're meant to, with BSS, go inside the eye and fracture something, like break the cataract, break the capsule, and irrigate so we can get a hydrodissection during the surgery, and we can go in there and break up pieces if we need to while continuing to give hydrodissection. This one here is a special one because this one will go on some sort of tip. It'll literally get applied to a tip so that you can go ahead and use this in the eye somehow. And this actually gets also applied to a handpiece, which will have suction and irrigation to a machine that goes ahead and pulses the fluid in and out, in and out. So at the time when you're fracturing in there, it's applying irrigation and it's suctioning back certain things, like a suction aspirator. This one is an old school one of giving your ultrasound technology. Just like your harmonic scalpel, this sends out waves and breaks down tissues. This is very old school though. You guys will not handle this one. You guys will now use a new Alcon phaco emulsification unit. That unit is all disposable. You might have tips like this, but it's a little bit newer than this one, right guys? Or did you guys use a disposable phaco or metal instrument phaco? Metal instrument phaco? So be careful. When you guys look inside, there is a little bit of sharp end, but it's not as sharp as a hypodermic needle. There's different size and tips and shapes depending on how the doctor likes to use his phaco emulsification unit. This is an old school unit, but it works similar. You will need to apply the handpiece, the application part, and then the actual tip depending on what surgery you're doing. Okay? So you can see some of these have different tips. Some of these already have, you see it has like a curved tip, so you can go in there and grab certain things. You have straight ones, so you can just go in there and irrigate if need be. There's some that are not even bored, which means all it's going to do is vibrate in the eye ultrasonically to break stuff down. Okay, different tips for different situations. All right? There's another tip here. So when you guys get here, please be careful. Don't just dip your hands in. Grab things one by one, and you can see different type tips. Okay, here, and then we're going to have fracture tomes. Okay, these fracture tomes have different hooks and little needles on there, so you can go inside and you can actually fracture by hand. Hardly used nowadays because we have the phaco emulsification unit. This used to take about an hour. Cataracts take about 2 minutes nowadays to finish. Yeah.
Wow.
So, yeah, because it's all in one handpiece. It has your cystotome, fracturetome, and all in one. All the doctor's got to do is change the system settings while he's going in there and shopping. You just stand there and chew your gum. No chewing gum in surgery, guys. Representation of a bad day.
Have you caught someone doing that in the OR?
Was that?
Have you caught someone chewing gum in the OR?
Yeah, but I wasn't working there. So those were my students. So, the only thing I've caught one of you guys doing is not wearing goggles. Yeah, shoot somebody out. All right, so during cataract surgery, we might need to put in a lens and replace the lens, right? So this is an IOL. Anybody know what that stands for?
Intraocular lens.
Intraocular. Good. Some of you guys are doing your case skills and reading. Listening to Dr. V. I'm glad. So today was a good day. All right. So IOL. Okay. There's difference in IOLs, right? Again, make sure when you guys grab any implant, I'll say you guys are breaking a little bit. Some of you guys are starting to do the dance. Anytime you get an implant or something going into the body, you must do what? Validate and verify. Validate and verify. So should you be opening anything ahead of time without verifying?
No.
So when you open something, guys, make sure you verified with at least one person in the team that has said yes. And if anything, don't even trust the nurse, trust the doctor. He knows what he's using, okay? What you could do instead to help the nurse is ask the nurse, do we have all the lenses in here? Yes, they're all over there. So guess what? During the timeout, when it says, do we have all that stuff? Sir, all the implants are on the table. If you want one open now, we can ask for that implant. If not, we'll wait till the point of insertion so we can make sure you give us the right diameters. Any mesh, guys, any implant, verify what size it is before you get it on your field. I've been to places where they open stuff and they're like, oh, that's not it. Why? Oh, the surgeon decided that it's a different size now. Okay. And guess what? The patient ends up getting charged for it. Okay? Some places did that on purpose.
Ooh.
I'm not going to say where, but you've seen them on the news or heard them on the news of pricing the patient with surgery and stuff. So what do we do to prevent that, guys? Make sure you at least have it in the room somewhere. You have different sizes so that we can get it when it's needed. Sometimes, and what they told, some of the techs told me here, they have a new device where this is already preloaded and it's ready to just get inserted into the eye. It's pretty awesome. But the only thing I don't like about that is these guys over here, if you guys see the little arms, you got to fold them in, put them into the device. Usually we have some somewhere. There's a little cartridge. You slip that into the cartridge with this guy. There's a little pusher on the end. So you grab it, slip into the cartridge, and then push the rest of it in there. Put a little bit of glue. We like to call it glue, but it's not glue. That visco. It's an elastic agent that goes into your eye. And then that gets inserted into the eye and it pushes out the little thing. And the little arms come back out. And the little arms hold on so that the lens goes nowhere. Okay? If this has been loaded and this has been sitting in the shelf for about a month, a lot of the memory ends up going out the way. So I'm pretty sure they're still going to have you guys load these things. The surgeons do not like to load these because they are the most difficult thing to load when someone's yelling. You guys thought loading a number 10 blade is difficult. Wait till you have to load one of these into a cartridge. John, did you have to load one of these or?
I was about to. I told my researcher that I don't feel comfortable doing it.
Yeah, the same thing he told me.
Good, guys, and that's the answer right there. You guys should be able to say, I don't feel comfortable, can you please show me? At that point, they'll be like, okay. They're gonna be like, get out! Because again, they know themselves, oh, I almost got away with loading it. I was gonna blame the student if it was wrong. So now they have to load it. So a lot of times, guys, someone is there, and if you don't know what needs to be done, anybody in this room, if nobody knows how to use this, what must be done?
Receptor.
Manufacturer. Call the manufacturer. Number one answer on your CST. Call the manufacturer. They should be setting you up for an in-service if nobody knows how to use that. Question?
So, like, what is the worst part about loading it? Is it?
There you go. The lens is found inside that little circle.
Okay. All right. Never mind.
And you gotta fold it like a little taco, and you can't break the little arms. And then you have to put a little juice on it. You can't touch it with your hand.
Wait. So it's that little thing all the way at the
This
top?
is an implant. Yeah. You'll see the blue little arms are the ones that hold on.
Wait, those
That
those
tiny thing? Oh,
Yeah.
receptor output.
it's that little dot at the top.
Call the manufacturer. Yeah, we call the manufacturer.
Yeah, I'm not. My hands are too big for that.
I mean, I went to a surgery center and everybody called off Paul's registry, so nobody knew how to do anything because everybody in there was registry. And we show up, and I've hardly done eyes. And the surgeon's like, "Can you load these?" I was like, "I haven't loaded them in a long time." He's like, "Better you than me."
The thing
So we both sat there, and everybody, shh. And then we all looked up, and yeah, keep going. Looked up, yeah, keep going. No, okay. Yeah, okay. We all made it. But then I said afterwards, you know what, you guys might need to in-service anybody else coming in here after this. Because at this point, it can be dangerous. Definitely if the surgeon doesn't even know.
I mean, like the tip.
At least, if anything, the main person using it should have been in-service on how to use this. Or have the representative there to continue to show what to do.
It's smaller than like the tip of a pinky.
Tiny.
That's like an air strand less.
Yeah.
Yeah.
You guys, wait till you see the sutures. All right. So they're different sizes. Why? There's a left and a right, right? But we don't call them left and right in surgery. Okay. Anybody know what they are? OSOD, okay, or S and D, okay. Now I want to show you guys the difference because this one is an IOL of a 17.5 D. Okay, does it mean the D of the eye? It means no. The diopter of the lens. Okay, this is the diopter of the lens. Make sure that your manufacturer, or when you guys bring these, it does say OS or OD or S or D. Please don't get confused with the D. That's the diopter. Usually the letter following the numbers are for diopter, not for left or right. Okay? So, but OD or OS, anybody know the meaning behind that?
Dominant secondary.
Kind of. Okay, so Catherine, hi. She's left-handed. Okay, so whenever you guys think of left-handed people, all right. So what they used to say back in the days is someone that is right-handed is good and is very skilled. And the person that's left-handed is not quite so skilled and is possibly even evil. Okay? That's what they used to say. Now, so what they used to say is dexterous side is your right side because you have dexterity. It means you can do stuff with your right hand. Okay, it's dexterous. You can put your brain and hand together. And what do teachers do? Use your right hand because it's more dexterous than your left. But shut up, use your right. Okay, that was back in the days, right? But now we kind of know now that you can use your left. It's a little different the way you hold your pen, weirdos. But
well, the worst. Well, if you're left-handed though, don't you have to worry about like smudging your hand on the ink or something?
yeah. So they have to write us like this.
Yeah, like because don't you have to like worry about smudging?
Those lefties.
So is it this compared to this? I mean, come on. I'm joking.
Right-handed person.
I'm joking. So, but because we were trained, again, that it's stick. Again, dexterous versus sinistrous or sinister. Sinister meaning bad. Okay, not good. So yes, it's still stuck, meaning right or left. It's more of a Latin term than anything. Again, dexterous and sinister. Again, remember, that is deal with left and right. Why don't we just say left and right? Remember, the body upside down with you not knowing is different. So a lot of times we like to use other meanings and terms and directions in surgery. That's why we don't say and the outside and the top, because on the top could be different, especially when you don't have the anatomical structure there. So that's why we use superior, inferior, posterior, anterior, blah, 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 blah. Dexterous, sinister, or sinistrous, okay? So now you guys have a better idea. So make sure when you guys grab it, you verify. If anything, write it down. When the doctor says, all right, we're doing the right eye, dexterous, right, sir? Yeah, sure, whatever, okay. Can you have me the dexterous IOL or the OD one instead, okay? It can be a simple mistake, guys. That simple of a mistake can be done in surgery, okay? By the way, I don't know if you guys have heard, there was a wrong side surgery like a week ago. Horrible, yeah. It was in Australia.
What happened?
Oh, the amputation.
Took the wrong leg.
Yeah.
Oh, by the way, we gotta go back in there and take the other leg now.
Oh. I'm sorry, but how does that happen?
How is that possible? Slacking off in lab. So we start here.
You can.
Okay, so
How do you identify the wrong leg? That won't.
slacking off in lab. It all starts here, guys. Literally, take it from here, take the knowledge that you guys can, and continue to be just as strict out there. Okay? Trust me, because you'll see people that are just meh. All right, and get into some final things. We're gonna have electrocautery, just like we mentioned over there. This is a little bit of a electrocautery bipolar type. Disposable compared to the one that was over there. there. Actually, the one was disposable. And then we're gonna have keratomes or diamond blades. These are your optical knives. Okay? So when you guys pass these around, please take these off and then pass them. Don't pass them with this on. You guys might get cut. This is one time use only. So as soon as this goes, this is used straight into your sharps as soon as you're done with the surgery. Okay? So these are diamond edged and diamond cut. So they look like diamond, right? But they also have a diamond edge cut. So these are one of the sharpest instruments in the world. Okay? Again, these are used this way. But when you pass, do me a favor, is don't pass it straight down because that's not how you use it. It's used this way, like kind of like a hockey stick or golfing, right? So what you want to do is also not having facing you. If there's any instrument facing you, all you gotta do is just face it to the side slightly. So when they use it, all they gotta do is direct this way. Okay? You do this way, it can go back up into you and then you cut it. So when handing this, you always hand instruments singular and sharp in this manner, but face it downward slightly. Not all the way because that's not how it's used. So do a slight pass, okay? So when you're done with this, please place it back in here, one person only. When handling this, please don't play around with those. We'll see, we'll uncover these guys. Super tiny, super big. So also depends on your surgeon and surgery. Make sure you grab the right one. This is 1.0 millimeters, that's 3.0, and this is a 5.2. You'll see different surgeries, right? On that one, you're probably doing cataract. On this one, you're probably doing vitrectomy. On this one, you're probably removing the entire cataract. Okay, or you're doing some iridectomy and fixing the iris or so. So different knives, different situations, and then also
So like, are those the sharpest instruments that are used in surgery, or what would you think would be the most sharp?
I haven't done the study on it, so
Oh.
I can't tell you 100%. All right, and these guys over here really belong in ENT. There's a little bit of eye stuff in here, but this is more, the short ones are mainly eye, but they're more ENT. Rosen picks and stuff, these don't belong. All right, so we're gonna go on break. When you guys come back, feel around.